So this is module 4 of the Make Cancer History Cancer course. The topic is surgery and radiotherapy, and recently radiotherapy has become quite a viable alternative for surgery in some situations. In the past, radiotherapy was associated with inoperable cancer. So this idea where you were told can't do surgery, it's too dangerous, or it wouldn't help enough to justify the risk. But now, recently, with new types of radiotherapy and with also just better cancer treatment and better cancer testing in general, it means that sometimes surgery can actually, radiotherapy can be an alternative to surgery, and radiotherapy does have some benefits. Typically, we think of surgery as the gold standard of cancer treatment because you're physically removing the cancer. And if the cancer hasn't spread too much, hopefully the surgeon can safely remove all the cancer and get clear margins, which means they take some healthy tissue from around the cancer, and they test the tissue around the cancer and hopefully find it's cancer-free. If not, they have to remove a bit more. But they do that so they can be confident of removing all the cancer. And this is why surgery is seen as something that we try to get to, especially if we have late-stage cancer. So you might be diagnosed at stage 4 like I was, and you're told, oh, you can't have liver surgery, you have an unresectable liver. And we might want to be kind of working towards liver surgery, or any other kind of surgery. But that is changing now. It's changing now with the gentler radiotherapies and more accurate radiotherapy. More accurate meaning it's more accurate at targeting the cancer and avoiding the healthy tissue. So we could look at surgeries in terms of their purpose, and we could also look at surgery in terms of the methodology. So some surgery is diagnostic, to actually diagnose the cancer for some certain types of cancer. And a very common surgical procedure, which I think as patients we wouldn't even think of as surgery, but surgeons certainly consider it surgery, is the biopsy. And there are various types of biopsy, like the needle biopsy, where a needle is inserted in to reach the tumor and take out some cells and usually some liquid, I believe, which is then analyzed. There's, of course, a biopsy during an endoscopy. So in the case of, for example, a gastroscopy, which is when a camera is used to investigate your stomach, the endoscopist may find some suspicious looking things in your stomach and can grab them with a little wire lasso on the end of the endoscopic device and remove them, and then these will be biopsied in a lab, in a histology lab. So the tissue is actually cut up and examined under a microscope to see if it's cancerous or not, and stained with various things that will show up if it's cancer. So biopsy is really considered in the medical world a kind of surgery, although for patients, we usually wouldn't think of it as a surgery. And then there's also surgery for staging, so kind of assessing how much the cancer has spread and for finding the size of the cancer, maybe in a situation where the scanning is not clear because of the positions of the tumors, it's hard to scan clearly. And then we often want to know if the surgery is curative or palliative. So curative means the intention is that you will be cured. So many early stage cancers fortunately can be cured by single surgery. In late stage cancers, unfortunately, the surgery is often going to be palliative, which means extending life, reducing side effects, reducing kind of damage that the cancer is doing to your body. So if a tumor is pushing against an organ, pushing against a nerve, that kind of thing, irritating a nerve, might have palliative surgery. But recently, again, the line is blurred. If you are in a country with exceptionally good surgical technique, then palliative surgery could actually be a step towards curative treatment, maybe combined with some other treatments and other surgery later on, or follow-up chemo, molecular target therapy, radiotherapy, and that kind of thing. So I mentioned before this idea of clean margins. So when the surgeon removes the tumors, they're looking for getting enough tissue out so they've got all the cancer and they're confident that the tissue around it is clear. So that's what surgeons talk about when they say they had nice clean margins. One thing to bear in mind with surgery is that when tissue is removed, it's all tested. So there's like testing in the surgery. So during the surgery, tissues are being tested. Then and there, liquids are being tested. So I had abdominal surgery 3 times, and part of the surgery they kind of washed the abdomen, and that liquid is kind of collected and tested at the lab to see if there are cancer cells floating around. So checking the abdominal washings is very important for abdominal surgery, because if the surgeon confidently removes all the cancer, but there are cancer cells found in that fluid around the abdomen, then potentially the cancer can spread back into the body, and that might affect the decision to do chemo or not after surgery. Because that's a really key thing, is do you do chemo after the surgery or not, to try and deal with the microscopic disease. So when a surgeon is doing surgery, they can see down to about 2 millimeters is what they can kind of see and remove. Typically they'll be removing it with an electrical device, not cutting it out when it's that kind of size. I've seen some video from my first surgery, and it was very weird to see this kind of probe device used to ablate the little tumors. Because the surgery I had was left colectomy, so that means on the left-hand side, part of my large intestine was removed. But also the surgeon did cytoreductive surgery, CRS. So cytoreductive surgery is for when the cancer spread and the surgeon tries to remove as much cancer as is safe to do. Cytoreductive surgery takes quite a while. In my case, there was 6 hours of surgery for that initial first surgery. Some of that, of course, is removing a primary tumor, and in my case, I had a colostomy formed where the end of the large intestine was brought out through the wall of the abdomen and terminated in a colostomy bag. But quite a lot of the time would have been spent hunting around my abdomen for tumors and then cutting them out if they were larger and ablating them if they were smaller. So when you hear about CRS, that's cytoreductive surgery, which just means trying to reduce the amount of cancer in the body. So as I said, like tissues and liquids are tested during the surgery, but you do need like a proper report, like a pathology report, and that will come some days later from the pathology lab. It's really worth getting copies of this kind of thing. So typically in surgery, when the tissue is taken, so the surgeon's going to be doing biopsies, so they're going to be removing bits of tissue, samples of tissue, and getting them tested. And they'll be obviously removing big tumors and things like that. And that tissue is washed and then pickled essentially with formaldehyde. And that can be used for genetic testing, but what it can't be used for, or not well generally, is to prepare immunotherapy treatments. So if you are planning to have immunotherapy treatments, a typical one would be dendritic cell therapy. You need to arrange that with the surgeon beforehand, ask them to keep some of the tissue for you unpickled, so not stick in the formaldehyde, and instead have that cryogenically frozen. And most surgeons will be cooperative. The only kind of sticking point is if they're doing genetic testing and they say, well, we need all the tissue for genetic testing. So that could be an issue. But the volume of tissue you need for dendritic cell therapy and other kind of therapies where they're using tumor tissue is about like a cubic centimeter or something, so like a 10 mil by 10 mil by 10 mil, so just a little bit. But if you don't arrange that with the surgeon, then all the stuff taken from your body is going to be like washed in acid and pickled, and it's not going to be good for preparing those immunotherapies. So you do need to arrange that in advance of the surgery. Now, the real challenge that the surgeon has of doing the surgery, apart from just achieving the goal of the surgery, the real challenge is the kind of tension between access and damage to your body. So the surgeon is always trying to get good access to safely remove the cancerous tissue, but they're trying to minimize the damage to your body, and especially minimize the incision. And this is a big problem, because you can imagine they want as much access as possible, but they don't want to cut a massive hole in you. So when we talk about the methods of surgery, we usually think of open surgery and keyhole surgery, also called laparoscopic surgery, I think. I'm not sure if I'm pronouncing that correctly. So I think keyhole surgery was originally developed for knee joints, I think was the original use. But now many surgeries can be done keyhole surgery. Some can't. Liver surgery generally can't, because your liver is right up inside your ribs on the right hand side, and the liver's massive, and I think it's the third biggest organ in the body after the skin and brain. So keyhole liver surgery is very unusual. Maybe that will change in the future, but that would be an open surgery. So an open surgery, you're going to get a big incision. Keyhole surgery, you're going to have much smaller incisions. So keyhole lung surgery, if it's removing a single tumor, that might be like a 3 centimeter cut. So that's 1.25 inches, I guess. I'm not good on imperial, but yeah, small incision, small scar. Also with keyhole surgery is it's generally safer because the wound healing is better because it's a smaller wound. So keyhole surgery, I'll explain the procedure in a second, but there are definitely cases where keyhole surgery has to turn into open surgery during the surgery. So the surgeons plan to do it by keyhole surgery, and then during the surgery they find that's not possible because of needing more access. So just because the surgical plan says keyhole surgery, don't be surprised if you wake up with a big scar where it changed to open surgery. So with keyhole surgery, a few holes are made in you, a few incisions. One will be used for So I think generally it'd be like 3. So one for the camera, one for the putting the tools in, and then one for putting the gas in. I think in some cases there might be a device with tools and gas in the same thing. And I think the gas is just carbon dioxide. So it's just to kind of inflate that bit of the body. So if you think of like abdominal keyhole surgery, they're going to puff you up with carbon dioxide to make enough room for putting the tools in and hopefully successfully cutting out all the cancer and getting those clear margins. So in my case, I've had one keyhole surgery, which was my colectomy and cytoreductive surgery. I've had 2 open surgeries. So I had a liver resection where about half my liver was removed and also the gallbladder. And then 6 years after my colectomy, I had stoma closure, sometimes called like a colostomy reversal. And that was when my intestines were reconnected. And that was an open surgery. That could often be done as a keyhole surgery. Mine had to be done as an open surgery because access was poor and it was my 3rd abdominal surgery. So there were concerns about adhesions. So with abdominal surgery, adhesions were a very big issue. This is where scar tissue forms between organs that should be able to move freely, or between just another part of the body and the organs. And adhesions, as the name implies, kind of stick you together, and they're not good. And it's unclear why adhesions form. They're caused by trauma, it seems. So surgeons try to touch your insides as least as possible. Surgeons try to use talc-free gloves or this kind of thing. But still, for some reason, some people get bad surgical adhesions and some don't. There is at least some evidence that taking the drug metformin can either prevent the formation of adhesions or even reverse them. So that's something to look into if you've had multiple surgeries like I have. Other options for surgery kind of related to the first 2. So you've got open surgery, you've got the keyhole surgery, but then you've also got the robotic surgery. The most famous robotic surgery system at the moment is the Da Vinci machine, which is a bunch of robotic arms, and that's controlled by a surgeon. So they're looking at a screen and they're manipulating these robotic arms that are doing the surgery. I guess at some point in the future, the robot itself will do the surgery using AI. But at the moment, my understanding is that in all use around the world, it's human controlled. And according to the companies behind robotic surgery, there's less damage, more precision, less chances of adhesions, quicker recovery. According to most of the independent research I've seen, this is not in general the case, that there doesn't seem much difference between a really good human surgeon doing it open or laparoscopic surgery, or the robot assisted surgery like Da Vinci machine. But in maybe some difficult complex surgeries, the robot assisted one would be better. And then another kind of common thing now is the stereotactic surgery, also called scanner assisted surgery or scanner guided surgery. So it's very common for surgery to use like ultrasound, like an ultrasound scan in the surgery to look at what needs to be cut out, but also even to guide the surgery of that. But now it's also possible to do MRI guided surgery or CT scanner guided surgery. So those are kind of the usual benefits you can imagine of having something that's scanner guided. So being able to see smaller things, being able to do more accurately, and being able to do less damage to the body. So just go over a few common surgeries just as examples of how surgery works. But the first thing I'm going to talk about is a laparoscopy. So a laparoscopy is like the keyhole surgery, but without the surgery bit. So that's just to check, to have a look inside the body, because there are many situations where a scan or multiple scans are not going to be sufficient. So, for example, in the case of where cancer is spread onto the abdominal membrane, the tumors in that case tend to be spread over the abdominal membrane, and they tend to be flat, and they tend to be small, around the kind of 2 to 3 millimeter size. And that means they typically will not show up on a scan. Scans are not good at seeing flat things. So MRI scans, CT scans, PET scans, they work best when there's some kind of depth to the thing they're scanning. And also, most of the scans, their maximum resolution is about 5 millimeters. So they're not going to be able to see something that's kind of 2 millimeters. So in the case of the peritoneum, that's the abdominal membrane, you'll see this thing written on the CT scan report where it says irregular thickening. And it's kind of a hint that the cancer spread, or probably spread, to the abdominal membrane. But what they're saying is it kind of looks bumpy, so it could have these little tumors on, but they didn't see a sort of big tumor where they could say that spread to the peritoneum, that spread to the abdominal membrane. So in that kind of case, a laparoscopy may be a good option, but you would need that done by someone who's very familiar with assessing the abdominal membrane. So ideally a surgeon who specializes in HIPEC, which is that special treatment for cancer that spread to the peritoneum, using a variation of the Sugar-Baker protocol invented by Dr. Sugar-Baker. A very, very common surgery is a lymph dissection. This just means removing lymph nodes and is often done during other cancer surgeries. So typically, any cancer surgery, I think, is going to involve removing lymph nodes to just see if they're cancerous or not. But for us late-stage patients, the cancer is often spread into the lymph nodes and they have to be removed. Depending on where they're removed from, it may be an issue for you or may not. For breast cancer surgery, unfortunately, the lymph nodes are removed from, or need to be removed in the armpit. And that can often cause like lymph buildup, like the liquid building up, the lymph fluid building up in the armpit, in the arm, which is uncomfortable and irritating, and has to be kind of dealt with massage or kind of elasticated supports and things. That is not nice. In the abdomen, so many lymph nodes are in places where in the abdomen where there's lots of nervous tissue, and nervous tissue isn't really easy to identify during surgery. So for example, I've had a lot of some quite important nerve tissue cut out in my abdomen when the surgeon was doing the retroperitoneal lymph dissection, which means getting the lymph nodes from behind the peritoneum, that abdominal membrane I mentioned. So lymph node dissection is very, very common. One of the most common cancer surgeries is the liver resection. Cancer often spreads to the liver because the liver is unique in the body in that it has 2 blood supplies. The liver is also very attractive for surgery because the liver is the only organ in the body that can regenerate essentially completely. So At the moment, the top liver surgeons are able to get, I think something like 60 something percent of the liver, maybe 57% of the liver they can safely remove and it will regenerate. Liver surgery can also be done in 2 steps because it regenerates within a few weeks. In cases where there's a lot of tumors and large tumors in the liver, it's possible to do a liver surgery, wait a few weeks, do a liver surgery again, and hopefully get a lot of the cancer out. Although in the case of liver surgery, lots of tumors, even if all the tumors are safely removed, it will typically be considered palliative treatment because it's very likely that there's kind of cancer spread throughout the liver. As I said before, liver surgery has to be done as open surgery in almost all cases because it's liver tucked up behind your ribs on your right hand side. One issue around liver surgery is that your liver is the organ that deals with chemo. So if you've had a lot of chemo, you might have poor liver function and you need to stop the chemo for quite a while before it's safe to do the surgery. You have to wait quite a while before you can restart chemo after the surgery. And that's scary when you're depending on the chemo to stay alive, essentially. Alternatives to liver surgery could be radiotherapy. So I've had proton beam therapy for the liver and tomotherapy as well for the liver, which are both types of radiotherapy. Radio frequency ablation, so RFA, that is, I'm not giving any medical advice, but RFA is maybe a treatment you will look at as an alternative to liver surgery. And RFA does not affect the function of the liver. So you can do it while on chemo without taking a break with your chemotherapy. So RFA is where a needle is inserted into the tumors under the guidance of, it could be scanner guided, or it could be ultrasound guided. Then the needle is heated with radio waves to ablate the tumor, which means kind of destroy it by heat. Cryotherapy is another alternative, so similar kind of needle, but freezing the needle to like freeze out the tumor. HAI, HAI, so hepatic arterial infusion, so kind of putting chemo directly into the liver with a device that's implanted under the skin. Or TACE, I forget what TACE stands for, but it's something arterial chemo embolization. So that's where like a catheter is put into your blood vessel in your leg, and chemo is kind of pumped into the liver that way. And I think TACE also involves putting little beads into the blood vessels that are supplying the tumor. So it cuts off the blood supply and puts a lot of chemo into the liver. So those are alternatives. Another place cancer spreads to often is a lung. So cancer spread to my right lung, but I haven't had surgery for it. I had radiotherapy and so far it seems to be okay. Maybe I'll find out soon that it's not okay, but at least at the moment it looks like on the scans. And so if you remember, your lungs have lobes, right? So we've got 2 lobes on the left and 3 on the right. The reason is because our heart is a little bit to the left of the center of the body. So if you've got lung tumors and they're kind of one side, you maybe have them removed by surgery. So the kind of 3 possibilities are, if it's just of one tumor or a couple of tumors very close together, you could do what's called a wedge resection. So as I said before, like a wedge resection for one small lung tumor could be done by keyhole surgery in many cases, and you'd have about a 30mm cut for that, so a little scar. And that surgery, when I was looking at having that surgery done, the predicted success rate for me was about 100% to remove a single lung tumor that was, I think, 3 or 4mm. So quite attractive, but yeah, instead I had radiotherapy, which had about an 80% chance of working effectively, and so far it seems to have worked. The reason I made that decision is that if I did the radiotherapy and the tumor returned, or cancer reoccurred in that part of the body, I could still have that surgery. So that's a consideration for lung surgery. Is one alternative might be radiotherapy. Another alternative could be radiofrequency ablation. So putting in the needle, heating up, cryoablation is another option. And of course, yeah, and always like chemotherapy plus molecular targeted therapy can be an alternative for surgery. If there are more tumors spread over a bigger area, then you need a lobe of the lung removed. So that's called a lobectomy. So you can have one lobe removed from the left side, which would be half of that lung, or a lobe removed from the right side, which would be a third of that lung. And if the cancer spread more, then you're going to be having a whole lung removed, which is called a pneumonectomy. So with cancer, unfortunately, kind of organ removal is, I guess, relatively common. So of course you can have a kidney removed. It won't grow back. With the liver, if you remove quite a lot of the liver, it will grow back. A liver is one of the, like 7 vital organs for life. So they won't remove too much, but they can safely remove kind of half at the moment. But yeah, you can lose a kidney, but if you have to lose both kidneys, then you're going to be on dialysis. For gynecological cancer, then yeah, removing ovaries or removing a womb, those things, yeah, unfortunately, kind of common in later stage cancers. So the alternative is called organ sparing surgery. So for example, when I had my liver surgery, on the scan, it looked like potentially the cancer had spread from the liver to the kidney. But I discussed with the surgeons, and they said if that had happened, if they found that to be the case during the surgery, then they would do a organ sparing partial nephrectomy, which means basically cutting a little bit off the kidney but leaving the kidney there, because I'm very attached to my organs. So yeah, it's I always kind of look for non-surgical alternatives. Surgery does suppress the immune system quite a lot, and obviously it's a lot to deal with, having your body cut up, spending time in hospital, maybe spending quite a lot of time in hospital. For my second and third surgeries, that was in COVID time in Japan, so no visitors are allowed at the hospital. So I had to kind of spend, oh no, so actually just the third surgery, no visitors were allowed in hospital. So I spent 18 days in hospital without friends and family being able to visit, which was, yeah, pretty tough. So if you're talking with a surgeon and they're talking about removing an organ, you might want to ask them about the possibility of doing organ sparing surgery. And if they say it's not possible, then you need to push them on that and say, is it not possible medically, or is it not possible because they're unable to do it at their hospital with that team. And another thing to push them on is, could it be possible in the future if I do another treatment first? So for example, if I am able to successfully shrink the tumors with chemo and molecular targeted therapy, could I then have the surgery and spare the organ? Surgeons like to do surgery, understandably, like in the best possible situation, right? Which means typically early, when you're in good physical condition. But sometimes we could have other treatments and then do surgery, and the surgery would be less damage to our body. So that's always something to look into. Another common type of cancer surgery is kind of removal of bits of the intestine. So I've had a colectomy, which means removal of some of the large intestine. So that's the kind of the short, large one. There is duodenectomy, jejunectomy, and an ileectomy. So depending on which bits of the small intestine are removed, there are those surgeries. They could be carried out and then your intestine could be reconnected during the surgery. If not, then one end, the upper end of the intestine is going to come out through the abdominal wall and is going to be terminated with a colostomy bag or an ileostomy bag. And then hopefully later on you can have a stoma closure. So stoma just means like the hole where the intestine comes out, or sometimes called like an ileostomy reversal or colostomy reversal, which is another surgery that can be quite big and difficult depending on the situation. So in my case, the colostomy reversal was a big surgery and difficult because the connection point was very low in my, like deep in my pelvis. So I was rejected for surgery by like 12 surgeons. The lucky 13th agreed to do it, and it was fine. It was a year and a bit ago, but it's just been fantastic not having a colostomy bag. And breast surgery. So there's the like lumpectomy, where a small part of tissue is removed. And then the bigger one would be removal of whole breast, which is the mastectomy, of course. And that surgery, especially if it's a mastectomy, is often going to include some kind of reconstruction afterwards. It's yet another surgery you have to deal with. I'll just briefly go over some of the issues with surgery. So you have morbidity. Morbidity is like the serious complications that cause some kind of disability afterwards. And then you have the mortality, which is either not surviving the surgery, or you often talk about the 30-day mortality or 30-day morbidity. So 30-day mortality is kind of the survival rate. Or I think probably the number that given is not surviving, the percentage that don't survive the 30 days after the surgery. So surgeons like to have risks down on quite a bit under 1%. So they're, when they say a surgery is safe, they're going to be looking at kind of 0.1%, so like 1 in 1,000 patient mortality. It's the sort of thing they look for. Lots of issues, discomforts after surgery that are temporary, problems eating, of course. Your intestines, if it's abdominal surgery, your intestines might stop working for a bit. This is called ileus, also known as lazy intestine. So you might be having like CT scans every day, and various things to try and get your intestines working, mainly early walking, early standing. Sleep issues, very common that it's really difficult to sleep through the night after surgery. Some of that is to do with like bladder control because you're often on a drip and you've had a catheter to empty your bladder during the surgery. Catheter's kind of traumatic anyway, particularly when the nurses remove it first time. That's incredibly painful. Very sore throat for quite a while after surgery is common. That's just from having the artificial airway put in and your mouth kind of held open for 2, 3, 4, 5, 6, 8 hours, or however long the surgery lasted. Pain, swelling, burning around the wound, common. And as it starts healing up, you still might get irritation, itching, and that kind of thing. And then more serious things, going into shock after surgery. I remember after my liver surgery, I was kind of shaking uncontrollably, which, I now know is shock. And I was kind of terrified that my teeth were going to break because they're like smashing together from the shivering. Unfortunately, when I woke up from the liver surgery, the first thing that happened is I vomited in my oxygen mask, which is very unpleasant. If you do vomit easily, or if you've ever vomited before after a surgery, when you do surgery, tell them that beforehand and they'll give you anti-vomit medicine. Another serious problem after surgery is, of course, some kind of infection. I had blood, I had a drip in my neck after the liver surgery and got an infection in there that was quite serious and had to be treated with a lot of antibiotics, and then it was fine. It was like a terrible thing, and it's just fine. So after surgery, like they'll be taking a temperature all the time. There'll be the nurse will usually be like asking you to measure how much you urinate. It's really important to do all that accurately because if you have an infection, you can often a symptom will be, of course, high temperature, but also things like urinary retention when you can't urinate. Another serious issue is some kind of bad reaction to the anesthesia. Another common thing is, or relative common, is like lung issues. So I've got pneumonia twice after surgery. After my liver surgery, I had pneumonia and a collapsed lung. Collapsed lung sounds very dramatic, but usually fixes itself in a few days. Pneumonia, quite unpleasant. When you have big surgery, you'll be encouraged to like cough, so early coughing after surgery is really important. You'll be given like deep breathing exercises to try and get air deep into the lungs. That's very painful if you've had a big abdominal surgery, but it's very, very, very important because it prevents pneumonia, but also if you do get pneumonia like I did, it will make it clear up a bit quicker maybe. Deep vein thrombosis, so kind of blood clots in your legs. So typically with surgeries of any length, reasonable length, you'll have to wear like kind of stockings to stop the blood collecting in your legs. You may also, when you're kind of woken up from surgery, you may find your legs in a strange massage machine to try and prevent blood clots forming in the legs. Another kind of serious issue related to that is blood clots going to your lung. And of course, bleeding and kind of wounds not healing well after surgery is an issue as well. I think if you're going to do a surgery, it's always worth looking for surgical trials, especially ones where it's like the trial is just to make the recovery easier. So if they're sort of looking at kind of a change to surgery that should get you out of hospital quicker or be less damaging to you, that's really worth looking at. And so briefly talk about radiotherapy, go into, well, it will kind of come up in future sessions as well, especially about making treatment decisions. But radiotherapy, as I said, can be a good alternative to surgery in some cases. And radiotherapy is kind of tricky to understand because it uses radiotherapy machines, and these are made by companies, and companies want to sell their machines, and there's a lot of nonsense around radiotherapy, like the naming of things and marketing. So it can be very difficult to know like what mode of radiotherapy is best for you. But briefly, we think of radiotherapy in kind of two groups. There's the ones that use radio waves, which are called gamma rays, or sometimes X-rays, and there's the one that use particles. So if you remember from school, we've got three forms of like radioactive radiation. So there's gamma rays, which are just waves of energy. There's beta waves, which are those electrons, kind of stream of electrons, and they go quite far. And then there's the alpha particles, which are the helium nuclei, and they're kind of big and heavy. So with radiotherapy, we can use gamma rays, which go forever. They get weak as they go along, so they attenuate. And with the particles, there's this kind of weird thing that happens, that you can get the particles to kind of stop suddenly, which means they do less damage coming out the back of the tumor. But the really strange thing is that you can also get them to kind of start suddenly, a few centimeters away from the source. So that means you can kind of really target the energy well into the tumor and damage less healthy tissue around. Sometimes radiotherapy will be marketed as if it's like a type of surgery, so they'll call it like a stereotactic surgery or stereotactic radiosurgery. It's radiotherapy, it's clearly not a surgery. But what they're trying to emphasize is maybe a single treatment, like a one session, to completely destroy a small tumor. Typically, radiotherapy, though, is given over several sessions. So I had proton beam therapy, which was 40 sessions. So it was Monday to Friday for 8 weeks, one session a day. Tomotherapy I had was like 20 sessions for one kind of treatment. So I had like 20 sessions, which was for the lung and liver, and then 20 sessions for lymph nodes. So with radiotherapy, they've got all these annoying commercial names like CyberKnife, Gamma Knife, Tomotherapy, TrueBeam, ViewRay. These are typically like scanner guided machines with various advantages and disadvantages. Gamma ray is like ancient now. It was made in 1967, so I think gamma ray couldn't have originally been scanner guided, because that's before CT scan, before CT scans existed. Gamma knife is now an old one that probably shouldn't really be used. That's used for head neck cancers, but you need to like immobilize the patient with a metal frame that's like pinned into the head, and it's unpleasant. CyberKnife and tomotherapy would be better, more modern alternatives, where you're kept still by like a mat that you lie on, and maybe some foam blocks around you, whatever. With head neck cancers, though, you're going to have some kind of mask to protect healthy tissue and important organs in your head and keep you still. A really important radiotherapy that is becoming usable is boron neutron capture therapy, which is a particle-based radiotherapy where you have a drug that builds up in the tumors, and that then is irradiated with a ray of neutrons, so like a stream of neutron particles, and they do the damage where that boron-based drug has been. So that allows the radiotherapy to kind of target local spread, and is a kind of amazing treatment. So that's just being used in Japan at the moment for head neck cancers. I don't think it's used much in the rest of the world, but it was only approved in Japan last year. But hopefully it will be used for a lot of things in the future. An issue with it though is currently it can't be done very deeply in the body, just a few centimeters. Another issue is with head neck cancers, you've got your lining of your mouth and throat and stuff that gets damaged easily by radiation. Another place where radiation is a big issue is the small intestine. So when you've got radiation for the abdomen, there's restrictions because the small intestine and also the stomach, they get lesions very easily from radiation. So stomach gets stomach ulcers very easily. And yeah, you could even potentially get like bowel perforation, I think, from radiotherapy to the small intestine. So the radiotherapist has to plan that kind of thing very carefully. If you're going to have radiotherapy, two things to consider to make it work better are radiosensitizing drugs. I don't think any are in standard use, but a whole bunch exist. So you ask if that's possible as part of either part of a trial that's going on, or if your radiotherapist could do it as like a case study. So that's using drugs that make the cancer cells more vulnerable to radiation. And a similar thing is using regional hypothermia therapy, which heats up the tumors and increases the blood flow. Increased blood flow means increased oxygen in the tumors, and oxygen in cancer cells makes the cancer cells weak to radiotherapy, because the way that radiotherapy works is they knock electrons off oxygen cells if it's a gamma radiation, and that's what does the damage, the oxygen ions. So if you have a more oxygenated cells, then you're going to get more damage from the radiotherapy. So kind of following on from that, well, how do you get the best radiotherapy? Typically what you need to do is search your cancer type for radiotherapy and see what modes of radiotherapy are being used and the results. So let's say you've got primary lung cancer and you're thinking of, can you have radiotherapy to the lung? So you're going to look for lung cancer radiotherapy, and you'll find papers that are comparing the results of like standard crude LINAC radiotherapy with CyberKnife, or comparing CyberKnife with proton beam therapy. So you need to look at those papers for your specific cancer type. Then you need to search for your country for that type of machine. So say you're based in the UK, so if you look at the manufacturer's website, the CyberKnife machine, they'll typically have a list. You might have to email them for it, but often it's just public available list on the website where all those machines are in the UK. And then you're going to look for those places and contact them and see if they will do your radiotherapy, or if your oncologist can refer you to that place. That's why it's really important to have a good relationship with your oncologist to get them to fight for the access for you. For surgery, ideally you want to do surgery at a high volume treatment center. So that's like, for your surgery type, they're doing it a lot day in, day out. So it's kind of a hospital where, let's say you're doing liver surgery, where they have a bunch of liver surgeons who are doing a lot of liver surgery, because you want the most experienced surgeon possible. You want to check that the surgeon has been at that hospital for quite a while, because you can have a very good surgeon who's recently moved to the hospital, which means that the kind of the cohesion with the surgeon and the team might not really be there yet, and that could result in poorer surgical outcomes. You can ask about the stats. So you can ask the stats for their hospital. So for example, when I had my colostomy reversal, there's a danger of leakage afterwards, right? They connect your intestines again, and it can leak, and that's potentially fatal and requires emergency surgery to fix. But the department at the university hospital I had that surgery done, their leakage after surgery was something like half of the national average, or may have even been like a tenth of the national average or something like that. And the national average for Japan is kind of similar to the internet, or even a bit lower than the international average anyway. So this essentially meant that this was a good place to do the surgery, because my situation was particularly difficult. It's a high chance of leakage, so I wanted to go to a department where they're getting really good results without leakage. Generally with surgeons, older and more experienced is better, because with good surgeons, their kind of physical skill levels pretty similar, but you want the surgeons with the good knowledge. You want the ones that are writing the papers, that are teaching surgery. And for many cancer surgeries, you want as specialist as possible. So, yeah. So I think, yeah, that's just an overview of surgery and radiotherapy. And both topics are going to be revisited in future modules, because of making decisions about, do you do surgery first or chemo first? Do you risk the surgery, or do you try another chemo if your chemo's not working? So these kind of difficult treatment decisions we're covering in future modules as well. And as always, you can watch all previous modules at makecancerhistory.jp. And thanks for watching.